Hi, my name is Renee Kreidl. I'm a geriatric fellow here at UCI, and today I'm going to be presenting polypharmacy cases. All right, so what is polypharmacy actually? It is any medication list that is nonsensical, regardless of the number of medications, although traditionally polypharmacy has been considered as 5 or more medications. A medication list can be nonsensical in many ways, including, but not limited to, inappropriately dosed medications for the patient's hepatic and renal function, taking 1 or more medications from the Beers criteria, especially if you're suspecting that the patient is having side effects, missing medications that should be prescribed under appropriate standard of care, taking supplements that have a high risk of interacting with an important medication, such as warfarin, taking medications that do not have a clear indication, which is fairly common, and taking medications that a patient has an allergy to, or medication that is closely related to it, and you suspect that the patient is having a reaction. What are some tools that you can use to address polypharmacy? Number one, your local pharmacist. They are a huge help. Number two, you have electronic medical record systems that do have automatic alerts. Although I know a lot of us do have alert fatigue and sometimes run through these, but please pay attention to these for inappropriate medications. You may have heard of the Beers criteria to address polypharmacy. There's also something that's a little bit newer called stop and start criteria, which we'll go over. So what's the Beers criteria? So it was first developed in 1991 by Dr. Beers. It was created by a panel of experts reviewing many clinical trials and research studies, and it describes medications with evidence that should be avoided by most older people outside of hospice and palliative care settings, avoided by older people with specific health conditions, avoided in combo with other treatment due to drug-drug interactions, used with caution because of potential harmful side effects, or dosed differently or avoided among people with reduced kidney function. So stop and start criteria. So stop standing for screening tool of older person's prescriptions, and start screening tool to alert to right treatment criteria. These were first drafted in 2003. It was a series of guidelines intended to help prevent inappropriate prescribing. The main concepts were to capture common and important prescribing errors, organized in a list by physiological systems, highlighting drugs that are risky to older adults with fall risk specifically, also highlighting duplicate drug class prescriptions, addressing potentially serious omission prescribing errors, and they wanted to represent this be a representation of collective of expert panel opinion on older people. It is more specific than beers, and it does have multiple studies demonstrating that it detects adverse drug effects better than beer's criteria, although beer's seems to be the most widely used still. So example of some guidelines from both of them. So for the Beers 2019 criteria, in regards to using aspirin for the primary prevention of cardiovascular disease and colorectal cancer in older adults greater than 70, due to major risk of bleeding, they recommend avoiding aspirin. Quality of evidence is moderate and strength of recommendation is strong. From the stop criteria, they have a number of specific recommendations in regards to aspirin. So they say no aspirin greater than 150 milligrams per day due to increased bleeding risk and no evidence for increased efficacy. No aspirin with a patient with a past medical history of peptic ulcer disease without an H2 block or a PPI on board, and no aspirin, clopidogrel, dipyridamole, or warfarin with concurrent bleeding disorder due to a high risk of bleeding. So on to some cases to practice polypharmacy. Use of megestrol acetate or Megace would be most appropriate in which of the following clinical cases? A 65-year-old male with early onset moderate Alzheimer's dementia who has lost 20% of his weight in the past 6 months and has a BMI of 17.5. Would it be C, a 71-year-old female with treatment-resistant major depressive disorder who has lost 8% of her weight in the past 3 months and has a BMI of 18.2? Would it be C, 80-year-old male with scratch the 72 there. It just should be an 80-year-old male whose HIV has progressed to AIDS and has anorexia and a BMI of 18? Or D, a 92-year-old female with metastatic breast cancer complicated by PE, anorexia, and now she has a BMI of 16.7. So most appropriate. Okay, so the answer would be C. So the patient that would be most appropriate for Megace would be the 80-year-old with HIV progressing to AIDS, anorexia, low BMI. So megestrol is a synthetic progestin, and it is FDA approved for anorexia, cachexia, or an unexplained significant weight loss in patients with a diagnosis of AIDS. A common off-label use is cancer-related cachexia, but as we had a patient, the 92-year-old female with breast cancer, but she had a PE, and caution is recommended in patients with a history of thromboembolic disease. And in terms of older adults with mental health problems, like Our Lady with major depressive disorder, they may have anorexia and may be underweight, but there is not enough data to support its use in this population. And just overall, megestrol is on the 2019 Beers criteria due to increased risk of thrombotic events and potentially death in older adults with minimal effects on weight. It should be never considered for weight loss in dementia patients. You would be surprised how many times I have seen it used in dementia patients. All right. Question 2. Choose the answer that exhibits a false statement. Would it be A, volume of distribution of a drug may increase with age due to increased body fat relative to skeletal muscle? Would it be B, renal function declines in older adults only if they have renal disease? Would it be C, hepatic function decreases with age? Or D, decreased renal clearance can prolong drug half-lives and head to increased plasma drug concentrations in older people? Okay, so the correct answer is B. And going back to B, so renal function declines in older adults only if they have renal disease. That is false. So renal function, unfortunately, declines in older adults regardless if they have renal disease. Same goes for hepatic function. And the combination of increased volume of distribution with increased fat versus skeletal muscle and storage reservoirs combined with decreased renal clearance can lead to increased plasma drug concentrations in older people. And just if you don't know what it looks like, this is a pill cutter exhibited on the right. Make sure that if your patient needs pills cut in half, that you're using a pill cutter. I have had patients who use razor blades in the past, so double check on that. Question number 3, choose which situations have polypharmacy. There may be more than one correct answer. These cases are kind of long. I'm going to skim them, but look over them as I'm reading them. 90-year-old female, hypertension, hyperlipidemia, diabetes, incontinence, melanoma, no current complaints. She's on amlodipine, lovastatin, metformin. Labs, normal. Cholesterol, normal. A1C, 5.5. No allergies. B, 75-year-old female, hypertension, hyperlipidemia, iron deficiency anemia, antiphospholipid syndrome, interstitial lung disease, OA, constipation, osteoporosis. She's having bilateral knee pain, but it has improved. She's on Docusate, 100 milligrams daily. She's on gabapentin. She's on hydrochlorothiazide. She's on hydroxychloroquine. She's on losartan, simvastatin, and warfarin. She has been on denosumab Q6 months for her osteoporosis, and labs CBC was normal, except she has a hemoglobin of 10 with low MCV. She has low sodium of 124, potassium 3, chloride 88, slightly high CO2, glucose 97, BU and creatinine normal. Allergies to penicillin was listed, but when you ask her, she just said, I had an upset stomach with Augmentin. All right, what about C? 91-year-old female, hypertension, hyperlipidemia, peripheral arterial disease. She has a heart failure with preserved ejection fraction, AFib. She has moderate Alzheimer's, hearing loss, osteoporosis, osteoarthritis. She was hospitalized recently. She had a stroke. Says post-thrombectomy, and family says she has regained much of her strength on the right side, eating well, sleeping well, needs some help with ADLs, but that's at baseline. No falls, no bleeding. She's on simvastatin, Eliquis, diltiazem, and I found out, talking to this real patient, that daughter administers patients meds, but patient's still taking some OTCs on her own. She reports using Tylenol and Advil intermittently for her knee pain. These are the last labs. Not sure about lipids. And then allergies listed were to atorvastatin, listed as itching, but daughter and patient are unable to verify this allergy. She is taking simvastatin currently and no pruritus currently. D is a 75-year-old male, history of non-ischemic cardiomyopathy, AFib, hypertension, hyperlipidemia, BPH with LUTS. No specific concerns, no shortness of breath, chest pain, palpitations, easy bleeding, and bruising. The patient is taking valsartan, rivaroxaban, carvedilol, vitamin C, and vitamin D. Labs look good, except cholesterol is high, including LDL. And when talking about the labs, patient says for several years he's been working on controlling his high cholesterol with diet and exercise. Has not been recommended previously to start a statin due to his insistence that he wanted to control with diet and exercise. Allergies, none. Okay, I know that was a lot, but the big picture is all of those patients, they are real cases from our geriatric clinic, and they all have polypharmacy. So I'm going to go through a number of the concerns that I had reviewing the patient's meds with them. So for our first patient, she has a number of very common diseases that we see, the triad of hypertension, hyperlipidemia, diabetes, also with melanoma, urinary incontinence. Note that she is on metformin. The A1C is 5.5. My concern is that given her age, she is 90, and she has multiple geriatric syndromes. So her A1C should be 6.5 to 7.5, or I'm sorry, if she had multiple geriatric syndromes or limited life expectancy. Please check out the ADA diabetic guidelines article for older adults. She should not be on metformin. She doesn't need it with an A1C of 5.5. For B, going back to B, 75-year-old, multiple conditions, lots of meds. So my concerns with that patient was, I don't know why she's on gabapentin. Diuretics are not a great choice, especially if they have a history of falls or incontinence or nocturia. And I couldn't find a recent INR on them, and they were on warfarin. So for C, let's go back to C. C was our 91-year-old, tons of comorbidities, moderate Alzheimer's. Uh, Surprisingly, this patient was doing quite well despite everything, including the recent CVA. So for her, I got pretty concerned because she's taking some medication on her own and she has moderate dementia. Although most of the drugs were managed by the daughter, and one of those medications was an NSAID, and she has already, let's go back to C, she's already on Eliquis, and although she didn't have any falls or bleeding, she has a number of risk factors for falls. So I would say this is a high risk situation. Get rid of the NSAID. But all of the other medications that she was on had a very clear indication and no obvious side effects. So I was okay with the other things there. D, let's go back to patient D. So 75-year-old male, heart disease, AFib, BPH, couple of different medications he's on, and then that high cholesterol. Okay. So I wasn't quite sure why the patient was taking vitamin C, but it's not a huge concern. It is a water-soluble vitamin, so if he's taking too much of it, it's gonna pee it out. And then I couldn't find a recent vitamin D level, and he was on a ridiculously high dose of 10,000 units per day. So I really couldn't figure that one out. And then patient's ASCVD risk score I calculated was 28.2. He wasn't on a statin. So I did discuss with this patient starting a statin, and we did end up starting one on him. One thing to consider about a statin is the life expectancy. You have to live for a couple of years before benefiting the most from this medication. So life expectancy, I'll go into a little bit later, can factor into whether or not you prescribe a medication for a patient. All right, I got another case for you guys. Mrs. MV, she's a 76-year-old, has a history of aortic valve replacement on warfarin, hypertension, CKD4, hyperlipidemia. She says she has 3 days of dysuria frequency and urgency. You check a UA on her, and she has positive nitrates, large leukocyte esterase, 55 WBCs, and patient feels like her symptoms are worsening, and you decided to treat empirically. She doesn't have any allergies, so what do you choose for this patient? So do you choose nitrofurantoin, 100 milligrams BID times 5? Do you choose Bactrim, BID times 3? Do you choose Cipro, 500 milligrams daily times 3? Do you choose Augmentin, 875 BID times 5? Or cephalexin or Keflex, 250 milligrams Q8 for 5 days? Give you a minute to think about that. Okay, so the answer was E, Keflex. A little bit unusual to be prescribing Keflex for a UTI. It's not typical, but let me explain why that was the correct choice. So nitrofurantoin, not an option. She's got CKD4. So if you have somebody with a creatinine clearance of less than 30, don't use it. It's likely safe for short-term treatment in patients with a creatinine clearance from 30 to 60, but she's already in CKD4. Bactrim. So Bactrim has been listed as a first-line treatment option for uncomplicated UTIs, but unfortunately, she is taking warfarin. That often increases the bleeding risk if they're taken together. So you could prescribe it, but you would consider making sure that the patient had close monitoring with an anticoagulation clinic around the time she was taking the treatment, or order INR labs for yourself. Ciprofloxacin, also same. So less than ideal options. Augmentin, it would be an option, but 875 is too high of a dose for CKD4, and it can have decreased efficacy compared to other agents. And so Keflex ends up being your option. It's an appropriate dose, 250 Q8, given that she has CKD4. It does not interact with warfarin. It is not a first-line agent, nitrofurantoin, Bactrim, or phosphomycin, but options in this case are limited. And so what are other ways besides the Keflex that you could have approached this case? So if the patient's symptoms were mild or stable, consider getting a urine culture before starting on antibiotics. If you have a patient with a history of recurrent UTIs, you could look at prior cultures to help guide your choice. I have done a lot of that before, and then still getting a urine culture to see the final bacteria and changing the antibiotics if necessary. Also, remember your local hospital or community has likely has an antibiogram, so consider checking that out before prescribing, given some increasing resistance to E. coli of antibiotics. All right. Next one, question 5. So which of the following medications can prolong the QT interval by themselves? There may be more than one correct answer. Citalopram, Zofran, Amio, Donepezil, or Aricept, Cipro, bupropion or Wellbutrin, or Izithro, your Z-Pack. Think about it. Okay. So all of them, A, B, C, D, E, except for F. F was bupropion. So all of those medications can actually prolong the QT interval on their own. There are a ton of other drugs that do so. Among the SSRIs, citalopram has the most potential to increase QT. Escitalopram and sertraline, two other commonly used SSRIs used in older patients, can do so as well, but less often and less severely. Donepezil can prolong QT and also worsen bradycardia. And then there are a lot of antibiotics that can cause prolonged QT. So including your azithromycin and your Cipro as seen here. Okay, those are all the cases for polypharmacy today. These are some resources that I have used that I have found really helpful, including the Beers criteria, the stop and start criteria, which I hadn't used a ton in the beginning of my fellowship, but really after going through them, looking at the research, they are worthwhile going through and noting what's appropriate and what's not. And please check out the American Diabetes Association Older Care for Adults Standard of Care. Very useful. And then if you want a list of meds that can prolong the QT interval, Kreidl Meds is a good resource. Thank you. And that is it for today.